So if you are new to this channel, I am Dr. Himadri. Let's talk about the management of tuberculosis in children. We will be discussing here about the latest NTEP, that is National Tuberculosis Elimination Program guideline. Okay, so 6-year-old boy presented with a history of fever for last 21 days and cough for last 21 days and weight loss for last 2 months. And also look here, there was TB contact history positive 1.5 years back, and also it was of his relative, and on examination there was mild pallor and cervical lymphadenopathy was noted, and also there was hepatosplenomegaly. So I ordered chest x-ray and it came out to be this. Look here, here you can see the fibrocavitary lesion present in the right lower lobe of a lung. So what could be the diagnosis? So we will come to it. Let's dive into our TB. So this is our National Tuberculosis Elimination Program. This is the latest badge given by Government of India. Look here, this is TB Mukt Bharat and TB Harega Desh Jitega, right? And this is under your National Health Mission, Ministry of Health and Family Welfare, Government of India. So how this NTEP came into play? You must be wondering that there was initially RNTCP dots like that. So look, the history started from 1962 when there was first the National Tuberculosis Program, after the 1997 RNTCP and dots, and after that 2005 to 11 RNTCP, second phase of RNTCP. Then we have a National Strategic Plan from 2012 to 17, and from 2020 the name came out to be NTEP, that is National Tuberculosis Elimination Program, and in our latest guideline 2021 and after the 2024 TB Mukt Bharat Abhiyan. Okay, so what is the strategy according to this? Look here, what we are doing in India is NTEP, and as per WHO, they are giving this the NTB strategy. This is for worldwide spectrum, and the goal is a world free of TB, zero death, disease and suffering due to TB, and the global TB epidemic. And what is the target here? So look, reduction in the number of TB deaths. So whatever existing case is present, the death should be reduced by 90% by 2030 as per SDG, that is Sustainable Development Goal, and also by 2035 it should be reduced by 95% as per NTB. So this data is compared with the 2015. Okay, these percentages are compared with 2015 data. So as well as there should be reduction in the TB incidence rate. Therefore the new case, so the new case should be reduced, and it should be reduced by 80% by 2030 as per SDG, and by 2035 it will be reduced by 90%. And also TB affected families facing catastrophic cost due to TB should be reduced to 0% in both in 2030 and 2035. So what is presumptive TB? Presumptive TB in children means if there is persistent fever for last more than 2 weeks without a known cause, and if there is unremitting cough for last more than 2 weeks, and also if there is 5% weight loss in last 3 months or no weight gain in last 3 months despite adequate nutrition, then we call it as a presumptive TB. As well as you need to consider here is that plus or minus, that is may or may not present TB contact history in last 2 years. Okay, so this is our presumptive TB case, and the first investigation you are supposed to do here is your chest x-ray, and the chest x-ray could be highly suggestive of tuberculosis. If it is highly suggestive, the second investigation is your NAT, that is nucleic acid amplification test. The NAT result consists of two data. One is this is positive. Positive means this is there is microbiologically confirmed TB, and second part of this result basically contains the rifampicin sensitivity or resistivity. Okay, if it is rifampicin resistant, we call it drug resistant TB. If it is rifampicin sensitive, we consider it and also we treat it as a first line drugs. Okay. So look here, the protocol is simple. If the chest x-ray is highly suggestive, do NAT, and in the CBNAAT or maybe the GL, that is gastric lavage, could be the specimen, or maybe your sputum, like that. And also if the NAT is positive, we call it microbiologically confirmed TB, and after that in the same report you will have this data like rifampicin sensitive or resistant. If it is resistant, we call it drug resistant TB. If sensitive, we use the first line drugs. And in this case, look here, the NAT may be negative. And what could be the possibility that NAT is negative when your chest X-ray is already highly suggestive? Look, suppose the TB is not present primarily in the lung, it could be present in your lymph node. So therefore, look for significantly enlarged peripheral lymph nodes, or maybe some case scenarios that TB is primarily present in the chest, but still your CBNAAT, that is your nucleic acid amplification test is not able to find it out. What could be the possibilities? Maybe your sample was not that good. So you can do a better sample, that is BAL. BAL is your bronchoalveolar lavage for this case. Suppose after doing CBNAAT from this BAL, suppose the NAT result came out to be positive, then we still consider it as microbiologically confirmed TB, and once again the same protocol, drug resistant or drug sensitive. And in this case, look here, if the NAT is negative in that case, but still your chest X-ray is highly suggestive and also the clinical features, we consider it as a clinically diagnosed probable TB. Okay. In the second case scenario, your chest X-ray could be non-specific. That is, non-specific shadow could be present. So what you should do, you should give appropriate antibiotics for 7 to 10 days, and after that you need to reassess this patient. Okay. And suppose this is a presumptive TB case, but the chest X-ray is totally normal. What could be the possibility? It could be your extrapulmonary TB. Look here. Suppose the primary TB focus is present in the GIT. Therefore, your chest X-ray would be totally normal in that case. Okay. So please consider it. Or maybe some lesions which is not been picked up by your chest X-ray. So CECT, that is a contrast enhanced CT scan of the, or HRCT thorax, may be needed in that cases. Okay. So what are the, so just now I have told that the chest X-ray should be, you should do, and what are those highly suggestive patterns of chest X-ray which is seen in tuberculosis? Look here, this is your miliary shadow. Miliary shadow means usually 2 to 3 millimeter dot shadows you can see, white opacities you can see in bilateral lung field. This is called your miliary shadow. Okay, this is seen in miliary TB. And secondly, the fibrocavitary pneumonia. So look here, you can see there are cavitations with some fibrosis present bilaterally, especially in this zone as well as in the left lung. Okay, so look here, this is cavitary pneumonia. So a cavitary pneumonia is present in the right upper lobe. So look here, what it is, this is a parenchymal lesion. Look here, this is a parenchymal lesion plus right sided paratracheal lymph node enlargement that you can see. Okay. So once again, there is paratracheal lymph node enlargement in the right side with right hilar lymphadenopathy. Look here, there is a consolidation present in the right middle lobe, as well as there is a contralateral lymph node enlargement. So these are few patterns which will tell you that this is a highly suggestive of TB. So never forget miliary shadows. This is number one. Number two, intrathoracic lymphadenopathy. In these patterns, that is your paratracheal or maybe the hilar lymphadenopathy. Third is your chronic fibrocavitary shadows. These three patterns are highly suggestive of tuberculosis in children. Okay, so just now we told that there is something called as NAT, that is nucleic acid amplification test. So look here, what we are doing today is cartridge based nucleic acid amplification test, NAT, for detection of Mycobacterium tuberculosis. Plus we check for the rifampicin sensitivity or the resistance pattern. Okay, so this is the cartridge. Look here, this is the cartridge. It is done by a company called as Gene Expert, and also this is actually Gene Expert, but the company name is yours Cepheid. And also in this Expert MTB or slash RIF, RIF means rifampicin sensitive or resistance pattern, and MTB means MTB is checked here. And also this is ultra. The ultra is the latest thing, you know, and the sample that you can use here is sputum or maybe induced sputum, gastric aspirate or other body fluids. Okay, and this is the machine. In this machine you need to insert this cartridge, and after putting the sample within it. So in CBNAAT, look here, this is the container which contains the sample, and this is the sample reagent. You need to mix it with this sample and after that transfer it to this cartridge, and this cartridge should be put into this machine, and within the machine there will be the ultrasonic lysis of that organism which contains the DNA, and in the second step there will be PCR, that is polymerase chain reaction, and after that in the report you will get two things. Number one is Mycobacterium tuberculosis detected or not, that is positive or negative, and after that rifampicin resistance pattern or rifampicin sensitivity. Okay, and for doing this report it takes around 2 hours, that is 1 hour 45 minutes. So what is the treatment? Once you know that this is a new microbiologically confirmed rifampicin sensitive pulmonary TB and also new clinically diagnosed TB, or maybe new microbiologically confirmed rifampicin sensitive extrapulmonary TB, that is maybe your nodal TB that is present in the lymph node or maybe in the GIT. In all these cases, the treatment should be 2 HRZE plus 4 HRE. That means 2 months of HRZE. H means isoniazide, R is rifampicin, Z is pyrazinamide, and E is your ethambutol. So these 2 months of intensive phase followed by 4 months of continuation phase. In the continuation phase, there are 3 drugs, that is isoniazide, rifampicin, and ethambutol. So look here, in the fixed dose combination, this patient was getting rifampicin and isoniazide. Therefore, the patient was on continuation phase. Okay, so there are 3 drugs: rifampicin, isoniazide, rifampicin, and ethambutol. Ethambutol is basically given as a separate tablet, but this is this combination FDC, fixed dose combination, which is given by your NTEP. Look here, National Tuberculosis Elimination Program. This is made by our NTEP, and also this is given as per the weight band. Okay, and as per the weight band, the number of tablets that should be taken daily. So one thing, these 2 months and 4 months of treatment, it should be taken daily. Okay. So look here, and apart from this primary treatment, what are the other treatments that you need to give? Number one is your pyridoxine. This pyridoxine means vitamin B6 tablet supplementation 10 mg per day should be given to all the patients who are receiving isoniazide. That is, all the patients receiving HRZE therapy, that is isoniazide containing treatment, should receive this pyridoxine, because isoniazide causes peripheral neuropathy and this vitamin B6 prevent it. Okay, and apart from this, other therapies here is your steroid. So what are the indications of giving steroid in tuberculosis? This is very, very important question. It will be asked in your exam. Okay, so remember why we are giving steroid. Number one is steroid decreases the inflammation related injury, especially within the brain. There could be the chances of hydrocephalus because of TB, that is TB meningitis. So reduce the chances of hydrocephalus and vasculitis by using this steroid. Okay, so what are the indications? Number one is your TB meningitis. Number two, TB uveitis. Then miliary TB with alveocapillary block. Number 4 is your Addison's disease, and also endobronchial tuberculosis and bronchial compression, mediastinal compression syndrome. These are important. Just don't forget TB meningitis, TB uveitis, miliary TB with alveocapillary block, and endobronchial tuberculosis. These are very, very important. And what is the steroid that we use? We usually use prednisolone at the dose of 1 to 2 mg per kg per day, or we can use dexamethasone. So once we have completed drug sensitive TB, now this is our drug resistant TB. So what is drug resistant TB, and rather what is probable drug resistant or probable multi drug resistant TB? So there should be the symptoms of TB that we have discussed, that is cough for more than 2 weeks and also fever for more than 2 weeks, and also there is weight loss or no weight gain in last 3 to 6 months. Okay, so apart from these symptoms, suppose if there is close contact history, known case of close contact history positive of MDR TB. Suppose a child having a patient in the home, and the patient is of MDR TB, multi-drug resistant TB, and also taking the treatment. Therefore, this child is probable case of MDR TB. Okay. Suppose in other cases, suppose the person is not diagnosed to be MDR TB, but during taking treatment, the person died because of this TB, or maybe some close contact with a person who failed TB treatment, or no response or failure of the first line regime or previous treatment with second line medication. So never forget, a person in the home with MDR TB, or the person is not yet to be diagnosed to be a case of MDR TB, but the patient died because of TB treatment, and this child is now was in close contact of that person who actually died few days ago. Or suppose the person was taking first line treatment and also not there was no response. Okay, so remember one thing, and their appropriate specimen fails to demonstrate MTB, and thus the resistant pattern cannot be determined to, or access to the specimen is not easy. Okay, the fact is that suppose the MTB, that is your MDR TB, multi-drug resistance pattern is not been yet diagnosed. In that cases, you need to consider all these histories. Okay, so suppose this is a case of probable MDR TB. What is the investigation? The first line investigation here is your NAT, nucleic acid amplification test, followed by LPA, line probe assay, as well as culture, and we do liquid culture. Okay, so look here. Just now we told that there is drug resistant TB. So what is called as isoniazid resistant TB? Isoniazid resistance means H, there is resistance to H as well as there is sensitivity present to R. So don't forget this. If there is resistance to H, there should be sensitivity. To R. This green means this is sensitive. Okay, H means resistance to H. This is called your isoniazid resistance TB. So what is called what is your rifampicin resistant TB? Rifampicin means only rifampicin resistance. Okay, and what is multi-drug resistant? Resistance to both H and both R, that is isoniazid and rifampicin, is called as multi-drug. And what is called your pre-XDR, that is pre-extensively drug resistant TB, resistance to both H, R as well as fluoroquinolone. And what is extensively drug resistant TB? H, R, fluoroquinolone plus class A drug like bedaquiline or maybe linezolid. Okay, so don't forget this, especially this is important. Isoniazid resistance means this is resistant to isoniazid, but at the same time it should be sensitive to rifampicin. Okay, rifampicin resistance means only R, so don't forget it. And this is your guideline for your multi-drug resistant TB. This looks very clumsy, very difficult. Okay, we will try to make it easy. Look here. So this is a presumptive MDR TB, or rather presumptive TB case. Okay, so the first line of investigation is chest X-ray. When we will discuss here all these approaches, so that you need not to go here and there. In a single page, all your approach should be done. Okay, so a presumptive TB case, for the first time patient is coming with a history of fever for more than 2 weeks, as well as there is cough, and also there is weight loss. So presumptive TB case, first line of investigation, chest X-ray. We discussed, suppose this patient have classical chest X-ray pattern, that is out of 3 that we have discussed. And the second investigation is your CBNAAT. Okay, so cartridge based nucleic acid amplification test, and this test result basically gives 2 data. Number 1, TB positive or negative, and number 2 is that rifampicin sensitive or resistant. Okay, suppose we are dealing with a person with TB positive with rifampicin sensitive. In that case, the second investigation here is the same thing, but look here, actually whatever sputum we are sending, the first sputum is actually given for your CBNAAT. Okay, and also the second specimen, second sputum specimen, we actually send it in the C and DST lab. C means culture, DST means drug sensitivity laboratory, and in this lab there is a machine which is doing your FLLPA. FLLPA means first line probe assay. So don't forget the first specimen, and whatever specimen we are giving, the first part of it basically goes for CBNAAT. If it is sensitive, they send it in the CDST lab, and this specimen for your FLLPA, and this is your first line probe assay. And in the first line probe assay, we actually check for the resistance to H as well as R. Here we check for the resistance of R, here we check for resistance of both H and R. Suppose in that scenario H is sensitive, then we have to give drug sensitive TB regime, that is we have already discussed 2-HRZE and 4-HRE. So remember, only so there is rifampicin sensitive, and also this is sensitive to H. H green means this is sensitive. So this is a totally sensitive TB. Okay, and suppose in that case you have H resistance in this first line probe assay, you get the result H resistance, but R is sensitive. Look at sensitive. So we have to give the treatment of H resistant TB regime. We will be discussing shortly about this H resistant TB regime. Okay, and suppose in that scenario the TB is positive and rifampicin resistance came out to be here, so we call it DRTB, that is drug resistant TB. So in this drug resistant TB, you need to give the second specimen. This is the first specimen. Second specimen should go for both of these two things, is first line probe assay as well as second line probe assay. So the difference is here the second specimen goes to for only first line probe assay if it is rifampicin sensitive. If rifampicin resistance, you need to go you need to give the sample for both first line probe assay as well as second line probe assay. So what the result you will get? Look here, the second line probe assay additionally check for the resistance pattern in the fluoroquinolone as well as class A drugs. Okay, so suppose there is age resistance is present, and this resistance is present only in CAD-G gene or in INHA. Okay, so either of these two, either in CAD-G gene. So remember this, your TB bacteria contains multiple genes which are responsible for their resistance. So this CAD-G as well as INHA gene are responsible for the resistance to this isoniazid drug. Okay, so either this CAD-G or INHA is responsible for age resistance here, and at the same time the person or this bacteria should be sensitive to fluoroquinolone. So in this case scenario, you have to give shorter oral bedaquiline based treatment. So this is actually your multi-drug TB or the rifampicin resistant TB case. So here we have to give shorter oral bedaquiline based treatment. Okay, suppose the age resistance is present both in CAD-G as well as INHA, or additional fluoroquinolone resistance is also present, we have to give longer regime. Remember, longer regime. So this is your MDR XDR TB, or that is pre-XDR to XDR, pre-extensively drug resistant to extensively drug resistant. So just now we discussed there is line probe assay. Line probe assay is another form of investigation, which is done in the second sample. So first line probe assay is also called MTB DR plus, and the second line is MTB DRSL, that is second line. Okay, first line check for the resistance pattern to H and R, and second line check for the fluoroquinolone as well as the second line injectable, and it gives the result within 72 hours. Remember, your CBNAAT was giving the result in 2 hours, but it gives the result within 72 hours. Okay, so another thing we have discussed, that there is something called as your LC-DST. LC means liquid culture drug susceptibility testing. Okay, so remember, if we put the bacteria in the solid culture, it will take around 4 to 7 weeks to come the result. Okay, but here if in the liquid medium we put it, we will get the result in 1 to 2 weeks. But at the same time, suppose we are putting this in MGT, that is Mycobacteria tube, growth indicator tube. Look here, this we can get the result even faster. Okay, so this is your MGT tube, that is Mycobacterium growth indicator tube. In the tube you have some reagent. Okay, so this is your fluorescence containing reagent. Okay, they are present initially in the FO2 form. Look here, there is a bacteria. If suppose there is bacteria, these are bacteria, yellow dot, so they will consume oxygen. At the same time they will produce carbon dioxide. So when they are consuming oxygen, they love to consume oxygen from this fluoroquinolone as well. So the oxygen will dissociate from not fluoroquinolone, sorry, this is your fluorescence molecule. And suppose this oxygen, when they are consuming oxygen, this oxygen will be dragged from this fluorescence molecule. So this fluorescence molecule becomes your free. Therefore they will give the strong fluorescence. Okay, and some talk about your community medicine here. Look here, TB under NTEP, they runs via different laboratories, and you should know it. This is the central division, this is the headquarter for your TB. Okay, and after that we have state TB cell, and this central TB division, they runs few laboratories. These are national level laboratories. Okay, there are total six laboratories in our India which are national laboratories for TB. So these are called as national reference laboratories, and in the state level we have IRL. IRL means intermediate reference laboratory. In the district level we have district TB center, and under this TB center we have TU. TU means tuberculosis unit, and one tuberculosis unit contains multiple DMC, that is designated microscopy center, and that is how when you are giving sample, they are basically screened from here. Okay, and eventually if there is any problem or a need for another investigation, they basically go via these steps and ultimately to the national reference laboratory if needed. Okay, so just now we have discussed multi-drug resistant TB and what is the definition for different types of resistance pattern. Okay. Now look at the treatment guideline. So if it is only rifampicin resistance or multi-drug resistant TB, that is resistant to both H and R, we actually consider shorter bedaquiline based regime, TB regime, oral regime. Okay. So we have already discussed, we just now simplifying this. Suppose in case of pre-extensively drug resistant TB or extensively drug resistant pre-XTR or XTR, we have to use longer MTB. Okay. And also in the isoniazid resistance TB, that is resistance to only age, there is age resistance regime. So look here, in the isoniazid resistance TB, what you have to do? Write the same thing, HRZE, but this is resistant to H, you cannot give H. In place of H, you have to give levofloxacin. Okay, so the regime here is levofloxacin, R, Z and E. It should be continued daily dose for 6 months. Look here, and what is your shorter bedaquiline based regime for your MDR TB or the rifampicin resistant TB? In that case, you need to write like this. So, you have to write like HZE. So look, we are initially we are giving in the primary TB, that is HRZE. Okay, so this is resistant to R, you cannot give R. So just give H, Z and E. Okay, and in the when you are writing age, just in the this side you have to write levofloxacin. But in case of Z, look here, there is also Z. So you are writing this CFZ. CFZ means clofazimine. Okay, and in the E, look here, this is also E. ETO, that is ethionamide. E is your ethambutol, but ETO means ethionamide. Okay. So in the H you have to write levofloxacin. In Z, you by the side you have to write CFZ, ZZ and also EE. Okay, and these 6 drugs should be continued for 4 to 6 months, and your oral bedaquiline will be continued for 6 months. This is the intensive phase, but in the continuation phase, look here, we have to give only Z and E. Look here, Z and E, H is omitted and ethionamide is also omitted. Okay, so just copy paste it and also cross here H and ethionamide. Okay, so what is your longer regime? You know, in pre-XTR and XTR TB, we are giving longer MTB regime. And here, bedaquiline based treatment should be continued for 6 months or more. And your, look here, writing this thing is also further easier. So this is your levofloxacin. And by this side, you need to write LZD, that is your linezolid. Okay, both starting with L. And here your clofazimine and CS here, this is your cycloserine. Okay, both C and both L. So this is so easy. So again revise. So in your isoniazid resistant TB, there is levofloxacin in place of H. But in case of rifampicin, that is shorter regime, just write HZE, levofloxacin, clofazimine and ethionamide. And here you need to cross both ethionamide and also H. And bedaquiline is not given in the continuation phase. So 6 months, 4 to 6 months, it is 5 months. And here this is further easier. Levofloxacin, linezolid, clofazimine, cycloserine, 8 to 20 months. And your bedaquiline for 6 months or more. So this is your group A drugs, bedaquiline, BDQ, linezolid, and in the group B there is clofazimine and also cycloserine. In the group C, ethionamide, pyrazinamide. Okay, so we have discussed the multi-drug resistant TB. Now just few words about management of TB with HIV co-infection and why we are rather so much concerned about HIV and TB. Look here. If a child is HIV infected, there is 18 times much more risk of having this TB, or if TB is present, the clinical disease will be much more severe. And also if TB is present and HIV co-infection both are present, in the HIV there will be AIDS. Okay, so this is a vicious loop, and the most dangerous thing about it is that this is extremely high death rate, around 15 to 18% if both of these disease occurs. Therefore, all the patients who are having TB positive should be screened for HIV. Okay, this is a government rule. Okay, so a child, and also suppose a child is HIV positive, that is CL HIV means child living with HIV. Okay, so in the CL HIV, of course we need to find out the TB is present or not. Here we have to ask for 4 symptom complexes. Number 1 is your current cough, fever, poor weight gain, that we have already discussed, and history of TB contact. that is these 4 symptom complexes if present, we actually consider it as a presumptive TB in case of CL HIV, and the first investigation here is not chest X-ray. The first investigation here is always NAT, that is nucleic acid amplification test. Okay, suppose in the NAT you find that this is a case of TB. So this is child living with HIV plus TB. What should be the treatment in this case? Look, the child is HIV positive, therefore child is getting ART, means antiretroviral therapy, and the most common ART which we use in children is TLD. Remember, T means tenofovir, lamivudine and dolutegravir. Okay, this is TLD. And as child now came out to be TB positive, you need to give 2 HRZD and 4 HRE. Okay, and in that case, look here, you need to just double the dose of DTG. DTG means dolutegravir. Whatever dose was child initially getting, you need to give the double dose of it, and it should be continued after even after completion of HRZD regime of 2 weeks. Okay, so this duration is actually 2 weeks. Here HRZD is completed, but another 2 weeks you have to continue this double dose dolutegravir, and after that the primary prophylaxis for TB of 6 months of INH prophylaxis should be continued, as well as you are giving INH, that is isoniazid, pyridoxine should be continued throughout. Okay. So the child living with HIV only, here TB is not present. Look, the treatment is ART, and also there is INH prophylaxis. In all the children who are HIV positive, you need to rule out TB if the child do not have active TB infection. For prevention of TB in all the children with HIV, you have to give INH prophylaxis, and along with COT, that is co-trimoxazole, is given to prevent opportunistic infection. And if child living with HIV with TB is present, just now we have discussed, you need to double dose the dolutegravir, and ART along with this treatment of TB should be continued, and after completion of it, you need to give prophylaxis of INH for another 6 months. Don't forget it. Okay, and also co-trimoxazole should be continued here. And another thing, you are giving HIV treatment for HIV and TB both. In that cases, there is high chances of your liver injury. Okay, therefore the baseline LFT as well as on day 15 of therapy, it should be repeated in 1 month, 3 months, and after that follow-up should be done according to symptoms. Okay, the management of neonate born to a mother with tuberculosis. How will you manage? Suppose this is a mother, and the mother is an active case of TB, and also mother is taking the treatment. And what should be the protocol for management in case of baby? Look, in that case, the only treatment is baby will be receiving INH at the rate of 10 mg. INH means isoniazid at the rate of 10 mg per kg for 6 months. Look here, you need to rule out the active TB infection in the child, in this newborn. Okay, if active infection of TB is not present, you need to give only INH prophylaxis for 6 months. And at birth, the baby should receive BCG at birth, and after the chest X-ray, and that is your clinical examination, and chest X-ray and CBNAAT should be done to find out active TB is present in this baby or not. If active TB is not present, continue this prophylaxis. Okay, and baby should be well breastfed, and baby and the baby will stay with mother. Don't forget it. Okay, so we were discussing about this case, and now you can tell what is the diagnosis. This is a case of pulmonary TB. Okay, the treatment will be here 2 HRZD and 4 HRE. So thank you. If you are still watching me, I know that this is a long video, but TB is much longer than this, and government protocol basically contains about 200 pages of this, and I tried to make it concise for you. And this is all for your MBBS exam and for your university exam and all that. Okay, so thank you. If you still like it, consider giving like and sharing with your friends, and consider subscribing to my channel for more such videos in future. Thank you.